Welcome to today's episode, brought to you by the Women in Medicine Summit, a transformational CME conference happening September 13th to 14th at the Drake Hotel in Chicago. Engage in leadership programming, learn negotiation skills, receive on-site coaching and mentoring, and see who will win this year's I Stand With Her awards. This year, we're excited to offer unique programming that includes a special session on how using improv comedy can bring fun back into medicine. We also have financial sessions tailored to help you navigate the complexities of personal and professional finances. Discover ways to advance into leadership roles, combat burnout, and either reignite your love for your current role or find joy in a new career path. Don't forget our Friday evening gala, a highlight this year you definitely won't want to miss. Register now at womeninmedicinesummit.org and be part of the movement that is shaping the future of healthcare. Join us to network, learn, and celebrate the power of women in medicine.
Welcome to the Revitalizing Doctor podcast. We interview trailblazers in medicine that embody the Revitalize Women vision to empower women to innovate and influence medicine, to value authenticity, respect, and work-life harmony. We recognize the challenges in medicine, and we're committed to providing coaching-informed strategies to help you go from surviving to thriving. I am very excited this morning and honestly a little bit intimidated to have both emergency medicine and lawyers on the podcast. So I'd like to introduce our listeners to Dr. Monica Saxena. She's an assistant professor of emergency medicine at Stanford University School of Medicine. She's also the 2022 recipient of the American Association of Women Emergency Physicians Faculty Rising Star Award. She completed her undergrad studies at Smith College and holds a law degree from University of Michigan and a medical degree from Wayne State University School of Medicine. She also completed fellowships in ultrasound and social emergency medicine and population health at Stanford. I don't know where she finds the time. During her social emergency medicine fellowship, she implemented an emergency department medication abortion protocol through which patients can present to the emergency department, receive an abortion, and be discharged. Prior to attending medical school, Dr. Saxena worked for the United Nations in Cambodia and taught courses at the Royal University of Law and Economics in Cambodia and Georgetown University Law Center in Washington, D.C. Wow. We also have Dr. Kimi Chernoby. She's a clinical instructor of emergency medicine at the GW School of Medicine and Health Sciences. She's also a reproductive rights lawyer. Kimi was the first graduate of University of Florida's MD-JD program and previously served as a health policy fellow for the Senate Committee on Health, Education, Labor, and Pensions. As a resident physician in Indiana, she helped pregnant minors obtain the right to consent to their own medical care, including postpartum contraception. Her work focuses on increasing access to contraception at the state and federal levels, specifically using clinical experience to advance policies that center the needs of patients. Wow. As a disclaimer, this conversation is for educational purposes and is not legal or medical advice. I'd like to say that with exclamation point, exclamation point, exclamation point. And probably by the time we finish this podcast, a law somewhere will have changed. So that's really important for everybody to recognize as well. Thank you, Monica and Kimi, for being on the podcast.
Thank you for having us.
Thanks.
So let's begin with ensuring we're all starting from the same set of facts. Can one of you or both of you explain the Dobbs decision and what it actually did?
Sure. So the Dobbs decision was a decision which overturned the federal constitution protection of the right to abortion. So going back many, many years, the Supreme Court actually found that there was a right to privacy in the marital home in a case that was about birth control and said that that right to privacy included a federally protected constitutional right to birth control. Subsequently, in Roe v. Wade, the question arose of whether that right to privacy also included the right to abortion. And the court said yes, that there is a federally protected constitutional right to abortion. And then under subsequent case law, it was narrowed down to a right to abortion prior to viability. And so that meant that prior to Dobbs, everyone in the United States had a legal right to obtain an abortion prior to viability. What Dobbs did was gave the Supreme Court the right to revisit that opinion. And normally they will defer to prior decisions under the principle of stare decisis, but it does mean that under exceptional circumstances, they can change their mind or revisit prior holdings. And that's what they did in Dobbs. And they said, look, we are going back to what we decided in Roe v. Wade, and we got it wrong. And we don't actually think that that right to privacy includes the right to abortion. And as such, the federal constitution does not protect the right to abortion. And because of the way our government is set up, that means that if there is no federal right, the decision goes back to state, and states are allowed to pass their own laws as long as they don't go against federal laws. And so that's why since Dobbs in the last year, you've seen the proliferation of state abortion bans of varying degrees.
Anything you want to add to that, Monica?
I think the big thing that's important for us as emergency physicians is how Dobbs is affecting our patients. One way we're seeing Dobbs is we're seeing a lot of these state bans, as Dr. Chernoby mentioned, that ban abortion, but don't really specify, even though they talk about life of the mother exceptions or life-saving exceptions, they don't really specify. So as EM physicians, one big thing we're seeing is our patients with ectopic pregnancies or non-viable pregnancies showing up in our EDs. And if there's a state abortion ban, there's often some confusion about how do we treat these patients, because as is well known, the treatment for ectopic pregnancy is functionally terminating that pregnancy. Now, it is a non-viable pregnancy, but it is still technically termination of the pregnancy. And what we're seeing in EDs that's kind of concerning is that doctors and hospitals don't know how to apply what is standard clinical practice under these abortion laws that don't really specify or take into account how medicine works.
So that's really scary. Monica and I live in California and practice in California. And I actually remember, I think I worked clinically the day after Dobbs, and I had she was in her second trimester, and anybody who works in emergency medicine knows these cases. She came in hemorrhaging. She was covered in blood. And I did what we normally do. I did a prompt pelvic exam. One of my tricks of the trade is I actually hook up suction and I place it at the base of the vaginal vault. I've never thought those large Q-tips do anything. And I removed the products of conception, standard care, because that stops the hemorrhage most of the time. And after I did that, I kind of had like this chill. And I said to everyone in the room, I said, just so everyone knows, the suction was in the vaginal vault. It was not inserted into the cervix. And I had never used that language before Dobbs because it never really crossed my mind that anybody would have thought that I was like performing an abortion, which I don't think I was. It was so weird. And that was the day where I'm like, I'm in California and I feel very scared that what I do may be misinterpreted, and I'm in California. So let's circle back to ectopic care because it really just blows my mind, because ectopic pregnancy is a very serious cause of death in pregnant women. And I believe in the first trimester, the leading cause of death. There is no way that an ectopic pregnancy will go on to be a successful pregnancy. So it blows my mind that this is even controversial, but I want to try to give, a framework for our listeners. So if you're working in a state in which let's start with which state has given the most restrictive. Can we use a concrete example of a state that's very restrictive right now?
I would say Texas and Florida. What would you say, Dr. Chernoby? And Tennessee?
I would actually not list those states because they include exceptions for health of the mother.
They do.
So let me pull one up.
They do include exceptions. My thought is that what we're seeing on the ground, just from some very preliminary survey data, is that doctors and hospitals are still struggling. Even though there's that exception for life of the mother, what does that exactly mean? They say the state of Texas will tell you that means ectopic pregnancy. But as we know in a current pending lawsuit, that's not actually what's happening on the ground.
So interesting.
I would just there's a big difference between health and life exceptions. And I don't know if that's the difference that you're making. So Texas and Florida have both health and life exceptions.
Right.
States like Idaho only have an exception for life.
Right.
And so would be considered more restrictive than a Texas or Florida.
Yeah.
So I didn't even know that. I think a lot of our listeners that'll be new knowledge too. So can you explain that a little bit more about the health versus the life exception? Stay tuned. We'll be right back. Are you a physician mom with school-aged children feeling utterly exhausted? My friend Dr. Sheeta Shaffi invites you to take a little time this summer to join her in a small, intimate group for meaningful conversations. Dr. Shaffi is an emergency physician, coach, and mom to 8-year-old twins. She understands firsthand what you're going through. This isn't a pizza party or a yoga class. You'll meet for 2 one-hour sessions twice a month starting in July to help you move out of exhaustion, let go of mom guilt, and live a life you're not only proud of, but can truly enjoy. Connect with her on LinkedIn or Instagram at Sheeta Shaffi to learn more. Sheeta is spelled Shideh, and Shaffi is spelled Shafie. You can also check the show notes for a link so you can connect with her there as well.
Yeah. So as states have passed these abortion bans, most include some sort of exception. And the question is how narrow is that exception? And so some states are passing exceptions that say an abortion can be performed if it is necessary to save the life of the mother or if there is some sort of imminent risk to the health of the pregnant person. And so those would include both. We would describe that as including both an exception for the health and the life of the pregnant person. Some states have taken it a step further and have only included an exception for the life of the pregnant person. And so that means if there's just an imminent risk to the health of the pregnant person, that wouldn't meet the criteria. In reality, as Dr. Saxena has mentioned, I mean, these are not playing out clearly. States, hospitals, physicians, lawyers don't know how to interpret this. And so, any ban is harmful to patients, and any ban means that patients are not getting the care that they need. But on a textual basis, some are written in a more restrictive manner than others.
I would just add that I think it's really interesting, and we can touch on this a little bit later when we talk about EMTALA, which is kind of our bedrock law as EM physicians. The court in Texas and the court in Idaho came out in very different, opposing decisions. And I think that truly is because of this distinction that Dr. Chernoby highlights.
The other caveat I will add is that when we use words, we use them in a way that means something to us, but words mean different things to different people, right? And so when we talk about ectopic pregnancies, usually what we're talking about is a tubal ectopic pregnancy. But there can be ectopics in other places that can be managed differently. For example, a cesarean ectopic. And when we say, all ectopic pregnancies are non-viable, we mean tubal ectopic pregnancies because there has never been a tubal ectopic pregnancy that has gone to gestate fully. But there are case reports of other ectopic, like intra-abdominal ectopic pregnancies that in other countries, where they have less prenatal care, have gone on to gestate fully. And so I think it's just important to know what we're talking about when we're talking about ectopics not being viable.
And Dr. Chernoby, may I ask, what has happened to those patients in those? I have not heard those reports before. What has happened to those patients?
I want to say there's 2 or 3 case studies of patients who, measured gravid and then they went to deliver and there was no progression of labor and they went to do a C-section and there was a hepatic ectopic pregnancy. And so the embryo had implanted on the liver and there was a blood supply and they had gone on, and they don't go well, but they do at least fully gestate. Now, I cannot say that there is any OB in the United States who would be interested in supervising a hepatic pregnancy, but certainly other forms of ectopic, like C-section ectopics, can be managed differently than a tubal ectopic.
Yeah, and that's such a great reminder of how complicated this topic is. But let's go ahead and spend some time on EMTALA. And, after Dobbs came out, I remember many EM organizations coming out and saying, don't worry, emergency doctors, everything's fine. We've got EMTALA. You can continue to practice the full spectrum of emergency medicine care. And now I'm having a little bit of chest pain listening to both of you say, well, it may not be that straightforward. And that's really why we wanted to do this podcast, because we are hearing, even me, I'm not an attorney, but I'm hearing cases of women that are told sometimes to go back out to the parking lot and sit. And when you have massive bleeding, which, what is massive bleeding, then come back in and we'll help you, which is infuriating to hear about. So can you try to explain what's going on there?
Yeah. And I guess I can start with a little bit just to review for all of us of what EMTALA is. EMTALA is our bedrock law as EM physicians, and it kind of underlies this idea, any patient, any problem, anytime. And, EMTALA has kind of 3 prongs. First, all patients that present to an emergency department requesting care receive a screening medical exam and determination of whether an emergency medical condition exists. So in other words, emergency departments, we can't turn away patients. And if an emergency medical condition exists, the hospital must stabilize the patient. And if they're unable to do so, they must transfer a patient to the hospital that can do so. And third, hospitals with these specialized levels of care, they have to accept these patients if they have the capacity to do so. And where we're kind of seeing the issue pop up is, kind of what is stabilization? That second prong, because again, in essence, the standard of care treatment for an ectopic pregnancy is termination of that pregnancy. But what we're seeing, as you just alluded to, is patients kind of being told, okay, sit in the parking lot until you're septic and come back. Or in other cases, and Dr. Chernoby probably knows a little bit more about this than I do, you're seeing patients being forced to go to hospitals far, far away from where they are to get this, again, basic standard of care. And it's really scary because, we grew up in medicine. I learned about EMTALA probably from day one, maybe my emergency medicine rotations and certainly in residency. And so we've been walking around practicing this way, and that really is at risk. And that's very, very concerning.
Yeah. So to give some context about how these laws interplay, we will go back to Section 6 of the Constitution, which establishes the supremacy clause. And like I mentioned earlier, we were talking about Dobbs. You can have state laws as long as they don't conflict with federal laws, because when there is a conflict, then federal laws preempt or have supremacy. And so in this case, what we're talking about is EMTALA as the federal law and EMTALA as preempting state laws that say that there's a ban on abortion. And so if a patient meets an emergency medical condition requirement under EMTALA and needs stabilizing care, which can include an abortion, then even in the face of a state abortion ban, EMTALA should preempt that law. And so that's where we're seeing, these lawsuits that Dr. Saxena mentioned in Texas and Idaho, where these states were questioning how EMTALA interfaced with their state abortion bans. But the ultimate, answer is that no matter where you're practicing, EMTALA is the law of the land. And so if an emergency medical condition exists, then you need to provide stabilizing treatment. And sometimes stabilizing treatment is an abortion.
So we've just talked about how the laws are changing all the time, and you two are both attorneys. And to hear that there's sometimes this level of confusion about what may be going on, I would imagine there's a few emergency physicians maybe having chest pain right now about what are they supposed to do on shift. So how can a non-lawyer try to figure out what they can do in their emergency department and how to navigate these very weird legal waters?
Yeah, it's tricky. Speaking from the perspective of a practicing emergency physician, take care of your patient. There are standards of care. Take care of your patient, and I do think hospitals, from what I've seen, are kind of responding and making these institutional policies. And you can, as Dr. Chernoby mentioned, rely on EMTALA. It's a little tricky, and I haven't looked at the law specifically at this, but, EMTALA is a federal law. And as Dr. Chernoby mentioned, we have the supremacy clause, the idea that if a state law and federal law conflict, the federal law wins. End of story. It's interesting, though, if we think about on the state level, for example, if a physician or an institution gets pulled into a state court for violating state law, would EMTALA come in and protect them? So that's just something I think we should just kind of know in the background. There's a little bit of confusion there. But to answer your question, what a physician must do is take care of their patient. There are standards of care. Ectopic pregnancies, by definition, are not viable pregnancies. So you take care of the patient and you, in some cases, have to terminate the pregnancy through an abortion.
Right. And I think what's important for the ED physicians listening to this is to realize that what we're talking about when we're saying do an abortion for an ectopic pregnancy is to give methotrexate. And, oftentimes I think physicians don't realize that that constitutes an abortion, but ACOG defines an abortion as any medical intervention that is provided to pregnant people that is intended to end the medical condition of pregnancy. And so giving methotrexate in that instance is performing the abortion. And it's the right thing to do. It's what we should do. It's supported by ACEP clinical guidelines, but this is why these things matter to us as EM physicians. My other word of advice would be you should be talking to your hospital system, right? Like you don't want to be determining this on shift. You should have some sort of plan in writing, preferably with your Office of General Counsel, risk management, your OB department. Like what is the agreement? What are we going to do about these patients when they show up into the emergency department at 3 a.m.?
Yeah. I want to put in a clarion call too, as EM physicians. As Dr. Chernoby mentioned, talk to your hospital system, but also get involved. I, as an EM physician, went in because I wanted to treat all comers. I just wanted to see any patient that came through the emergency department. That was part of the appeal to me. And, this is our chance to stand up for our patients. This is our chance to advocate for our patients and us in the practice of medicine. So that does mean getting involved with all those organizations that are doing great work, including ACEP. Even SAEM has a task force. SAEM isn't much of an advocacy organization, but they're also doing some work. And I think it's just really, really important, especially for those physicians in places where there are kind of this gray area, this ambiguity, these questions, to really stand up and one, first share what's going on, and two, advocate for our patients and the practice of medicine. This is kind of our clarion call to do that.
So I recently hired an attorney to have on retainer for business related things. It was my first time hiring an attorney since I got a divorce. And it was just kind of interesting going through the process and like, okay, yes, send this check. And then, this is the retainer. And I'm wondering if you're a physician practicing in one of these very restrictive states, would it be, I may hire somebody to have on retainer in case something comes up like this, that knowing that these states are very contentious and that, I guess I would be skeptical of if the hospital would have my interests, my medical license truly in mind. Is that like overreaction? Or would you at least have like some names of people that if you were potentially in being under review, that you could know that you could reach out to these people quickly if you needed to?
There's actually a lot of resources for physicians who would find themselves in trouble related to providing abortions. A lot of nonprofits a lot of the reproductive rights groups have gotten together to create an abortion access legal defense fund. And so there is both help in terms of lawyers who can help as well as financial support for those legal costs. And so I think the idea of every EM physician retaining a lawyer in the event that they might provide life-saving, abortion care for their patient who is miscarrying or experiencing some other pregnancy complication we might not be at that point yet.
So that's great to hear. So, Monica, can you walk us through what you're doing at Stanford now that we're in this post-Dobbs world for how long? I don't know. And we're having more women show up really needing abortion care, management of inevitable miscarriages, maybe crossing state lines, things that they would have done in other states. Now they're showing up in our emergency departments. What are you doing at Stanford?
Thank you. So at Stanford, what we have is a medication abortion protocol. And as you noted a little bit earlier, what that means is any patient who presents to the emergency department and has a pregnancy for which they do not wish to continue for whatever reason can receive the medications for an abortion and be discharged later that day. There are the two medications. The first medication is mifepristone, commonly called Miffy. And what that does is it blocks progesterone. So basically, we need progesterone to continue pregnancies. And so what happens is if progesterone is blocked, the lining of the uterus breaks down, the pregnancy cannot continue. So what happens in our protocol is the patient is given that medication. Then they are also given the second medication, which is misoprostol, which they take about 48 to 72 hours later. And that simply just evacuates the contents of the uterus. And that medication they're actually taking at home. So while the second medication and the final completion of the abortion is at home, they are started on that pathway and given the prescription for the medication to take at home. So they, in essence, do have, they are on their way to having a complete abortion by the time they leave our emergency department.
And to clarify, that protocol is only for first trimester. What's the week cutoff?
Yeah. So we cut off around 9 to 10 weeks, which is where ACOG cuts off as well. There have been some case reports of people doing it later, but to comply just in terms of risk management and making sure that we're protecting our ability to practice medicine and our ability to provide the service, we cut off around 10 weeks. There is some leeway with that if you're 10 weeks and 3 or 4 days. Our friends in the OB/GYN department upstairs do come down. And so we do have a little bit of leeway with that. But in general, we're saying 10 weeks.
And you brought up a couple of medications that have been in the media a lot. So could one of you walk us through what has been going on legally with the medications? And as a quick primer for the listeners, so we mentioned earlier in the episode methotrexate, and that is preferred for ectopic management. And then you just mentioned mifepristone, which is also known as RU486, and misoprostol. In the United States, the standard protocol for medical management of miscarriages and elective first trimester abortions includes mifepristone and misoprostol, which you described how those medications are administered. So what have we been hearing about these medications? What was actually decided recently in some of these court decisions?
Well, I can start with the REMS surrounding mifepristone, and then Monica, I don't know if you want to talk about the lawsuits, but mifepristone is unique in that it is controlled by something called a REMS, which is a risk evaluation and mitigation strategy. And so that is something that is put in place by the FDA. And so unlike other medications where you can write a prescription and it can be dispensed from any pharmacy, like I write a prescription for amoxicillin, you take it to CVS and it gets dispensed. Mifepristone could only be dispensed in certain settings. And so previously it was that mifepristone had to be dispensed in clinical settings by a physician. That changed during COVID because they said, well, public health emergency, it is more risky for patients to have to go to an abortion clinic to get this in person. And so then during COVID, it could be dispensed via mail, right? And so that's how we started to see teleabortions. The REMS was officially updated after the COVID-19 pandemic, or during the pandemic, actually. And they said permanently, yes, that this can be dispensed over mail. It doesn't have to be dispensed in person anymore. And it could be dispensed by pharmacies as long as the pharmacies participated in this program. Additionally, not anyone can prescribe the medication. So you have to also participate in the program to prescribe the medication. So if you come to most emergency departments and you're having a miscarriage, even though we have studies showing that management is improved if you get both mifepristone and misoprostol, most EM physicians are not participants of the program and so cannot prescribe mifepristone. And so that's why most patients who come to EDs for management of miscarriage will continue to get misoprostol alone if they're offered medication at all. And so the status of mifepristone right now with regard to the REMS is that it can be dispensed by pharmacies and it can be dispensed by mail. However, the pharmacies have to participate in this program. And so we haven't yet seen the retail pharmacies sign up for the program. It's an ongoing process, but we expect that large chain pharmacies will soon begin dispensing mifepristone and that it can be just written like any other prescription, although providers will still need to participate in the program themselves.
Large chain pharmacies except Walgreens, to be clear.
Depending on states, yeah.
Yes.
And to participate in that program, is that by states? Does it vary by state or is that a federal?
It's through FDA. So you register with FDA to participate.
And it's very easy to register, I would add. It's just filling out a form and sending it in.
Oh, awesome. So any listener that would like to be, because from the brief literature review I did this morning, that is the preferred protocol and more effective and less painful, less bleeding for women if they do the combo mifepristone, misoprostol. protocol. I mean, that's fantastic news. I mean, I'm kind of frustrated that I graduated residency in 2015 and I'm just now getting that knowledge now. But I think it's also a reflection of, typically the demand curve was such that a lot of these patients I referred to OB-GYN. I live in California. We have a lot of Planned Parenthoods, and it just wasn't really something I had to know that much about. It wasn't that I didn't care. It's just there was enough other avenues for patients to get this care.
I will put in a plug for the team program. So, I was the same way. When I started residency, I felt like the training I got was, if patients are coming in miscarrying, then you can discharge them with OB follow-up, and we call that expectant management. But we weren't offering them either a D&C in the emergency department, or we weren't offering medication, even though we know that medication increases the completion of the miscarriage and can decrease symptoms and, has many other benefits for patients. And so it was in residency that I became interested in this topic. And so there's this group called TEAM out of the University of Washington, and it is an affiliation from the Department of OB/GYN there, as well as they work with an emergency medicine physician. And they will come and train your hospital ED group on how to manage miscarriages. And that means that they will teach you medication management as well as procedural management. And so they came and did a papaya workshop for the IU residency while I was a resident there. And they trained us all on how to do hands-on manual uterine aspirations. There is literature that shows that this is practical and can be done in EM, right? So with the proper training, EM physicians should be able to offer aspirations for miscarriage management. Certainly all EM physicians can and should be offering medication management for miscarriage. But if you want more training, they are a great group and would highly recommend reaching out to them.
I would just add our colleagues down the road at Highland Hospital are doing MUAs in the ED very successfully and have kind of integrated that into their clinical practice in the ED.
And they're the ones who, had partnered with TEAM to do the EM side. They're amazing.
Yeah.
And for our listeners, the MUA is the manual uterine aspirations.
Yeah.
And you did mention, Kimi, papaya, right? The fruit.
Yes.
That's how you do the simulation training related to it.
Yeah, the papaya is a great sim model. The stem makes for a perfect cervical Oz, and you can aspirate all of the seeds.
Yeah. I love when my worlds collide, because I don't know if you both know, I'm a simulation educator. I've not done that simulation, so I better get on it.
Highly recommend.
Yes.
Awesome. Well, this hour has just flown by. One of the things that we do on this podcast is we really cater to the women physicians out there that want to have a bigger impact and maybe do something a little different. And so both of you are like poster women of this podcast, because you're attorneys, you're JDs. So for the listeners out there that may be thinking that they want to go to law school, what is your advice for being both an MD and a JD, or a DO and a JD?
I mean, I would say do it. I have had a blast. So I split my time on 80% FTE at a law organization, and then I work clinically on weekends. And I feel like having the two has really informed both sides of what I do, right? So when I work in the emergency department, I am very familiar with the laws that I'm practicing under, and I find that very satisfying. But I think more important aspect is that I use my clinical work to inform my legal work. So when I was working at the Senate, or where I'm working now, it's, I saw a patient who had this, and I know exactly the barriers that we're facing in delivering this care, and can think critically about how we can solve those problems. And so I really enjoyed being able to integrate the two. Obviously, it is time consuming, and going to law school is no small undertaking, but for me, it's been a huge reward.
How did you do it? Did you do med school, then law school, or can you explain that?
So this was poorly thought out on my end. So I did a combined program, which existed on paper, and I got to UF and I was like, I'm here for your MD JD. And they're like, oh, that's so great. It's on paper. No one's ever done it. No one's thought about this. So I did my first 2 years of medical school, and then I did 2 years of law school. And then I went back to third year clinical rotations and did my third year of law school at night, which is where things really started to get hairy. And then I graduated law school at the end of my third year of medical school. And then I took the bar exam during my fourth year of medical school. So then I graduated at the end of 6 years with my MD and was a licensed attorney.
I'm just having like chest pains listening to that story. That sounds very intense. Monica, please tell me yours was a little bit smoother.
It was a little bit of a different path. I went to law school and practiced law. And, I decided I wanted something a little bit different, looked at a lot of different options and landed on medicine, which is a longer conversation why. I will tell you it was probably one of the best decisions I've made in my life. But to answer your question, and I think it's probably relevant for anyone who's kind of thinking of making the switch, who's listening today, it's our life experiences matter. And when you come to these changes in your career, these pivots, and you bring all your life experience with you, you really kind of have an enhanced education and can do better for the people you're serving. I certainly could have gone to medical school at 22 or 25. I don't think I would be as good of a doctor as I am today because I come in with all that information and that lens. The residents who work with me on shift will tell you I am constantly talking about medical malpractice and defensive medicine and how not to get sued. And and that it enhances everything I do. It enhances my patient care. It enhances my teaching of residents, and all of that I bring because I was a practicing lawyer. The only thing I would say is when you go back to school and you're I was in my 30s, people 40s, 50s, whenever you're doing it, it's tough to be a student again. Your mind just kind of works differently. And I tell people I didn't realize I had an ego until I went back to medical school in my 30s and I was taking orders from someone who was 25 and this was their first job ever. It was a struggle, but ultimately, you come out and you're just so well prepared to deal with kind of, especially in emergency medicine, all of the things that we deal with. We're this specialty, we're complex, we're rapidly changing. We need to adapt to different environments. And when you have kind of these skills that you can throw at it all together, it makes you a better doctor and you take better care of your patients.
I will say also law school, they have night programs. They have programs specifically for people who have other careers. It's like a 4-year program. So it's a little bit of a lower course load per semester. And so it's not impossible to do.
Yeah. And I taught in one of those programs. And I'll tell you, those were kind of I taught in the day program and in the night program. And the night program, the students were just so fascinating. And so like in law school for the right reasons, and they were there and they had a goal and they just brought so much more perspective to the classroom discussion. So for anyone who's thinking of doing it and kind of pivoting or maybe going to law school and bring it into their clinical practice, do it. You're going to bring such a perspective to the classroom discussion. It's going to enhance everybody's learning. And, email me if you want to do it. We can chat more.
I love that. And on that note, a lot of our listeners are feeling a little burned out. 65% of emergency physicians, in fact, are burned out. So obviously you two are very passionate about the healthcare of all patients, especially women. And it's been, I can say the fuck word on this podcast. It's been a fucking year, God, this anniversary of Dobbs just happened. And I don't even, what's a bad anniversary? Is there a word for that? I don't know, but that's what it is. How do you guys stay energized and not like just F it, I'm moving to New Zealand?
I mean, I think about that often. New Zealand thing. For me, it's the change in pace, right? It's like every Monday I get up and I go to work and I fight for the right to birth control. And I find that incredibly rewarding. And then by like Thursday when I'm like, oh my God, another meeting, I'm like, oh, tomorrow I get to go to the emergency department and like, who knows what's going to walk through the door. And so that kind of constant change in what I'm doing in my day to day keeps me really engaged and motivated. And then I had a baby recently. And so that's really fun and exciting and keeps me happy about life as well.
Amen to all of that. I think it's really wonderful to step back and, look at why we became emergency physicians and what kind of drives us. And that kind of brings me back to, hey, I've got to go in and, fight another day, whether that means fighting as in doing something with the hospital, my policy, or advocating for my patient, but just remembering that we chose this. And again, I think like many of us, we chose this very thoughtfully. about why we chose emergency medicine and kind of bringing that every day and just taking 2 minutes and checking in and reminding myself of that. And the other thing I would say that has really helped me with burnout, especially as I kind of transitioned from training, residency fellowship and now attending, is to really, really shore up my relationships and my life outside of medicine. That has sustained me immensely. And it's very tough to do while you're in training. You barely see, postmen, or you barely go to the store. You barely interact with anybody, I felt like, in residency. And to really kind of foster those relationships has really sustained me, especially in a time where we feel like we're constantly attacked. Our bodily integrity is being attacked. If I can have those people around me, I know protect me and nourish me and see the world the same way I do, it's very, very wonderful and protects me a little bit from getting burnt out or angry. Not that I don't, but it helps a little bit to have that barrier.
Wow. Well, you two have just been a breath of amazingly fresh air. I am feeling more enthusiastic and channeling that fight inside of me that we can do this. How can our listeners connect with you? Because I have a feeling they're going to want to tweet at you, connect with you, message you. Are you active on social media or have a website?
Yes, I am on Twitter, and my Twitter handle is at Kimi Chernoby.
I am on Twitter as well. It's at Monica R, capital R, Saxena. Email, always email me, and you can email me at my Stanford email, which is saxenam@stanford.edu. It might take me some time to get back to you, but I promise you I will.
It has been a pleasure having you both on the podcast, and I want to have you both back on and talk more about work-life harmony. And we didn't even get into Kimi being a new mom and pumping on shift and all that kind of amazing stuff. So I hope to have you both on soon.
Thanks so much.
Thank you for having me.
Thanks for listening to The Revitalizing Doctor, a project of Revitalize Women Physician Circle. Our mission is to connect women physicians and allies through innovative, value-based coaching methods that align trust, support, accountability, and skill development to ignite the courage and clarity necessary to take bold actions, create change, and thrive. If you're interested in working with us, check out our website at peoplealwayshcc.com/revitalize or email us at revitalizemmm.info@gmail.com. This podcast represents the views of our host and guest. It does not reflect the views of any institution we work for or with.
Hi, it's Dr. Risa E. Lewis, dropping in to tell you about a book that Dr. Adara Landry and I wrote. It's called Microskills, Small Actions, Big Impact. It's a business self-help book coming in 2024 by HarperCollins. Pre-order now. Microskills, Small Actions, Big Impact, wherever you buy your books.